Hi, everyone. Good morning, and I'm happy to talk to you today about a variety of topics. And right here, I'm going to talk about acute complications associated with diabetes. In class, we got all the way up to this point, and we even started talking about it, but I'm going to repeat it right now. Important to recognize that when a patient is diabetic, we have uh, really effective management strategies, particularly when we're talking about type 1 diabetes, around the use of insulin, monitoring well, sometimes dietary changes. But we've moved a little bit away from the diet control or to be able to allow someone to have a much more flexible lifestyle. But regardless, we need to watch for complications, both chronic or long-term complications, and as well as those that are acute. So the first one we're going to talk about is diabetic ketoacidosis, or DKA. DKA is often precipitated by an illness or an infection, sometimes by inadequate insulin dosage. For example, many of you may have heard on the news about how insulin is so expensive in the United States that people actually ration their insulin and they're not able to give themselves the required dose. It could be that you're not giving yourself enough insulin for the amount of carbohydrates that you're taking in, something like that. But it would have to be over a long period of time. Most often we see DKA under several conditions. One, when you have a new onset of type 1 diabetes, you haven't been diagnosed and you're not taking insulin at all. Or when you have a type 1 diabetes, but you're ill, flu, vomiting, diarrhea, some other condition that causes either your inability to manage your blood sugar levels effectively because of your not being able to determine how much you're taking in, and also when you're unwell, your blood sugars really rise. Characterized typically by a high blood sugar, so that hyperglycemia, and because you don't have you have an insufficient amount of insulin, glucose can't be properly used for energy. And so what your body does in order to get energy is it starts breaking down fat stores. And a byproduct of that breakdown of fat stores is the release of ketones. So ketones are a byproduct of fat metabolism. And the release of those ketones into the bloodstream actually alters your blood pH, causing a condition called metabolic acidosis. Ketone bodies are excreted. Our body tries to get rid of them by excreting them in our urine. And because we're excreting them in our urine, we become very dehydrated because we're passing copious, very large amounts of urine trying to pass those ketone bodies. We also, as we breathe them out to try to rid our body of them. And I think I talked about in class that some people can actually smell those ketone bodies, a fruity smell. I cannot. It's just genetic whether you can smell them or not. And again, most typically it's in type 1 diabetes versus type 2. It is possible in both. So let's carry on with that a little bit more. Signs and symptoms of diabetic ketoacidosis. Polyuria, which means that passing copious amounts of urine, so voiding very frequently. It could be every 15 minutes, just voiding, because your body is trying to pass those ketone bodies as a way to bring that pH back to normal. Polydipsia, so you're drinking massive amounts of water, again, as part of that process, and you're becoming quite dehydrated. Very lethargic and weak, and that can be an early symptom as opposed to a later symptom. Remember, we've talked about this process of how your body is trying to rid those ketones, and so you become dehydrated, and we see the signs and symptoms of dehydration there. So poor skin turgor, your dry mucous membranes, your body is a compensatory process for that dehydration. Will increase your heart rate. So you'll see a tachycardia as a sign of moving towards a profound dehydration, and that orthostatic hypertension. So that's hypotension that occurs that we see not necessarily when a patient is lying down, but if we take a blood pressure when a patient is lying down, a patient is sitting, and then a patient is standing with a couple of minutes in between each one of those measurements, then we'll see a drop in that blood pressure when we see a positional change from lying to sitting or lying to standing. Interesting that we also see the signs and symptoms associated with abdominal pain. Often we see some vomiting and diarrhea, again, as a side effect or a side consequence of this, and that acute abdominal pain. When we look at lab findings, Often we see a blood glucose greater than 14, and it can be very high in the high 20s, in the 30s, even beyond, very high. We see an arterial blood pH of less than 7.35. Do you remember a patient is acidotic? Sorry, that's my dog. Metabolic acidosis, and we see a pH of less than 7.35. Bicarb as well as low. Remember, we're acidotic, so our bicarb level is less than 15. We see an anion gap that's greater than 12 millimoles per liter, and moderate to large ketones in the urine. And we just dip that. We dip it the way we dip for red blood cells or leukocytes in the urine. We can also dip for ketones. And that's a really quick, easy, very first test if you're suspecting that. Diabetic ketoacidosis is a serious, often life-threatening condition. We need to treat it very promptly. And depending on the signs and symptoms, patients are typically hospitalized. It would be rare that you're not hospitalized, but depending on the kind of care that's required and how we are able to reverse that, if it's in the very early phases, it may be that a patient is just kept in the ER or in an observation area for 24 hours, typically admitted though. We also see this Kussmaul's respirations, and that's where a patient, again, remember I said that not only do we pass those ketone bodies in our urine, we pass them through our respiratory system, helps us to try to blow off those ketones. And in trying to do that, then our body moves to a process where we're taking these fast, deep breaths as we try to blow those ketones off. It's not that we can control it. A person, sometimes people think that the patient is hyperventilating and try to get them to calm down or give them a brown paper bag that you might give someone when they're hyperventilating. You should not be doing that. This is a compensatory process where our lungs are trying to blow off those ketones, and you see very deep, very rapid breathing. And again, you can smell that, that fruity odor. So what is our goal here? Well, we've got this profound fluid and electrolyte imbalance. And so what we want to do is restore the fluid balance. We can do that by giving half normal saline, so that's 0.5% normal saline, or more often, really typically what you're going to see is normal saline. So that's 0.9% normal saline. And you're going to typically provide a bolus or a fast infusion until we can bring that person's fluid balance back up closer to normal. We're going to watch their urine output. In the old days, we would have always put a catheter in. Remember, we talked about that in class, HAUDI, hospital-acquired UTI. We like not to put a catheter anymore. So we're going to be able to monitor a person's output by either, if they are very unwell, having them urinate on the bedpan or with a urinal, or helping them to a bedside commode, or even going to the bathroom, depending on how well they are, how young they are, how mobile they are, a whole bunch of other things. We also want to bring their blood pressure back to within a normal range, or a normal range for that person. And we want to watch that orthostatic hypotension reverse. As blood glucose approaches 14, and that's kind of an important number, as it approaches 14, we want to move to adding some 5% dextrose to the regimen. And that's because what we don't want to see is that we overshoot, right? So we overshoot this correction. You've got let's say you've got a blood sugar that is 38, and we're bringing it down, and we're bringing it down fairly quickly. And as we bring it down, we actually overshoot and get to a state of hypoglycemia. So we're going to actually add some 5% dextrose, and we're going to start looking at whether we need potassium replacement, and we're also going to look at whether the patient needs sodium bicarb. It's important to recognize that the first thing we do is that volume replacement, right? So that volume replacement is really critical, and then we're going to watch for how we manage then the nuanced care of a patient as they move to a place closer to a normal range. It's really important, again, that we don't begin. I think your first thought might be that this person's blood sugar is so very high, we need to give them insulin. We want to be careful that we rehydrate a person and we get a much better picture of what their actual blood sugar is once they're rehydrated, before we begin trying to reverse the situation of DKA with insulin. So we're going to move quickly to that rehydration. We talked about that either with half strength normal saline or normal saline. And then once their blood sugar is approaching normal, we're going to look to insulin therapy as well as the other things I just talked about. And we're going to typically provide a bolus of insulin intravenously, and there's only one kind of insulin that we give intravenously, that's regular insulin, followed by an insulin drip. And that insulin drip is going to be regulated based on their blood sugar findings. So it's really important to recognize that we regulate that to effect. That means not every patient's going to have the same protocol. We typically start, depending on what their blood sugar looks like, in roughly the same way, but we're always going to be doing Acute checks and regular blood draws to see where a person is at and regulating their insulin drip to within the range that's been ordered. What insulin does, and remember we talked about that, it allows both water but also potassium to enter the cell. And as that potassium is entering the cell, glucose enters the cell as well. What we need to watch for is, because that insulin drives potassium into the cell, a patient may actually become hypoglycemic. So they might actually end up with a low potassium level. So we have to watch that, and we may have to look to some treatment. It's important to recognize that before we have corrected the DKA, when a person is profoundly dehydrated, they've got a very high blood sugar, and because they have no insulin, their potassium could look elevated to start, right? So it's a very nuanced understanding. So when a person presents with DKA and you take their first blood results, their potassium could look high. That is not an accurate representation of the physiological process that is happening. Once we rehydrate them, begin an insulin drip, bring their blood sugar down, that insulin then drives the potassium within the cell, and often the patient is not hyperkalemic, so they typically don't have a high potassium. Often that potassium is actually low and we need to correct it. So just to be cautious of that and to recognize that that is a fluid process. Another acute complication is HHS, hyperosmolar hyperglycemic syndrome. This, somewhat like DKA, is life-threatening, but it is less common. And whereas DKA we most often see with patients who have type 1 diabetes, with HHS we see it with patients who have type 2 diabetes. So remember, when you have type 2 diabetes, you typically still have insulin. And so that because we have insulin, and insulin allows our body to metabolize glucose, we don't need to move to metabolizing ketones instead, or metabolizing fat, which leads to ketones instead. So in HHS, we're not going to see that ketoacidosis. So in the early stages, we actually have fewer symptoms because we don't have all of that. Polydipsia, polyuria, breathing out ketones, all those early signs. But what happens is we have that increase in serum osmolality instead. And so we often see, interestingly, neurological complications. So common causes of HHS in a person with type 2 diabetes include infection. Often the source of infection is the urinary tract, pneumonia, and sepsis. And again, sort of like type 1 diabetics who have DKA, any kind of acute illness that causes a stress response may lead to this process of decompensation. And for a type 2 diabetic, we see this HHS. Also, similar again to DKA for a type 1 diabetic, for a type 2 diabetic who is newly diagnosed, or who has acquired type 2 diabetes but not yet been diagnosed, we may see this. Often also we see a history of inadequate fluid intake. So a person who's already dehydrated moves towards HHS. We're going to see symptoms such as some polyuria, not to the degree that you're going to see in DKA for sure. Blood glucose levels can be higher than 34. An increase in that serum osmolality, right? Because we've got those high glucose levels. Remember, no ketone bodies. Sometimes you just may see them most minimal, but really, when we're looking at how we would characterize it, typically we say no ketone bodies. This is a medical emergency because we see a very high mortality rate So again, therapy is going to be similar to DKA, except interestingly, this HHS for the type 2 diabetic requires much more fluid replacement. So we often think type 2 diabetes has fewer complications than type 1 diabetes. That's a misnomer, a misunderstanding of the disease processes, and it is indeed life-threatening. So let's look at another acute complication, hypoglycemia. And I think you all know about this. You've probably learned about this through health classes in life and certainly in this program. So hypoglycemia characterized by low blood glucose, right? And it occurs when either we take too much insulin in proportion to the amount of glucose in our blood. So in trying to figure out how many carbs I've had and what my dose of insulin should be, I take more insulin than would be appropriate for where my blood glucose is sitting. And it's characterized by a blood glucose level of less than 4. Common manifestations, we might see diaphoresis, tremors, a feeling of hunger, and sometimes they're a little bit vague. So you might see anxiety, nervousness, things like that. Patients often, we also see a pallor, and they may feel those heart palpitations. It's quite an uncomfortable sensation to feel that hypoglycemia. If it's untreated, that can progress to a loss of consciousness, seizure, coma, and death. It is a life-threatening condition. It's interesting, it can also mimic alcohol intoxication. So a person who has a low blood sugar, people often think they've been drinking. My niece is a type 1 diabetic, and I was with her and my sister once at a gas station. We had stopped to get gas, and I don't know, everybody decided we were going to go in and get pop or something like that. And my niece, who was 17 years old at the time, I think that we decided to go in and get a pop because she was feeling low. We went in, and she suddenly acutely dropped her blood sugar and had a seizure there in the gas station tuck shop. It was quite a difficult moment. It feels scary even for me as a nurse. And we had to call the ambulance, take her to the hospital, and she had just got her driver's license a couple of months earlier, and that unfortunately was revoked for 6 months. So many, many complications, and including there can be a death from that. So let's carry on with hypoglycemia. We want to treat that if a person is alert with 15 to 20 grams of a simple carbohydrate. So that might be 175 mils of fruit juice and a regular soft drink. We also want to follow that up with something longer acting. So we give the short acting sugar to get right into their bloodstream, but we don't want them to spike and then drop really quickly. So let's say we give them a can of Coke to drink or some other pop. I don't want to promote Coke. And then we would give them a chocolate chip cookie. So something with a carbohydrate that's a little bit more complex than that simple sugar. So we've got the short-term immediate acting and a longer term. Additionally, if they are alert enough to swallow, we're going to recheck their blood sugar every 15 minutes. You might check it more often. Leslie and I were at a pool recently, and somebody had an acute hypoglycemic event, and they would not, it was just kind of a crazed situation. The daughter of the person who was very hypoglycemic would not, first of all, would not identify that they had a glucometer, and then would not let us use it. In any case, you might even do it a little bit more often than every 15 minutes, depending on the situation. And really never hesitate to call an ambulance, to call EMS to get some support through the process. And you're going to just repeat this process until you have a blood sugar greater than 4. Sometimes it'll require much more glucose, so several doses of that to get a person up to greater than 4. And then we want, once a person has returned to normal, we want them to eat their regularly scheduled meal or snack or other kinds of things through the day, right? So it's really important that we haven't brought them up and then they drop again quickly. Important that we've checked them several times. We've dosed those simple carbohydrates to bring them up greater than 4. About 45 minutes later, so not even an hour later, we want to check again to just watch that trend and make sure that we're not moving to hypoglycemia. At the same time, we don't want to give them so much simple sugar, pop, fruit juice, other things, that they end up with a rebound hyperglycemia. And that's why we look at that sort of simple carbohydrate in that sort of standard amounts and keep checking their blood sugar readings. You can find commercial products, there's gels or tabs or other kinds of things that have specific amounts of glucose. Those are often really convenient for carrying in your purse or your pocket and can be used in situations like this if you're not at home. So now we've moved on from acute complications to talk about chronic complications. And those can be really devastating. So you think, oh, chronic is not so serious. It can be very devastating, both for life and lifestyle. So let's talk about macrovascular, right? So those are diseases of the large and the medium-sized blood vessels. And those occur with greater frequency and an earlier onset in diabetics. We also see microvascular damage, and that's a very tiny capillary level. And we see that often to the retina, and that happens because of that chronic hyperglycemia. Most common cause of new cases of blindness in people of working age are associated with that microvascular damage to the retina caused by hyperglycemia. And for that reason, people with type 1 diabetes should have dilated eye exam within 5 years of the onset of the diabetes and repeated annually. We see here that patients are at greater risk of stroke, of hypertension, of atherosclerosis, and we've talked about all of those things when we talked about cardiac, problems with your kidneys or nephropathy, coronary artery disease, islet cell loss, and that's in their pancreas, and we know we've talked about the physiology and pathophysiology of diabetes. Peripheral vascular disease, including peripheral vascular atherosclerosis, where you have a loss of blood flow to a part of their body and a resultant, sometimes gangrene. Erectile dysfunction is very common to have peripheral neuropathy, and patients may experience that in their feet or their hands, and that can be really devastating for lifestyle. Neurogenic bladder, where you have associated urinary complications and very high propensity for infections. Oh my, look at this. This is a really good example of a foot ulcer, although not something we like to look at. Shows you when a patient in particular has that peripheral vascular disease and lack of good blood flow to their feet, and also at the same time that peripheral neuropathy. So you may not feel what particularly well what's going on in your extremities. You can have development of foot ulcers associated with a lack of blood flow to that area. They can be devastating. They can take months to even years to treat adequately, and often we hear of patients with both type 1 and type 2 diabetes having to have amputations, which is really, again, when you're thinking about the experiences of a person and their life and their lifestyle, really profoundly devastating. Okay, let's try a knowledge check. We've got a client with type 1 diabetes. They call the clinic with symptoms of nausea, vomiting, and diarrhea. What should the nurse tell them? Hold your regular dose of insulin. Maybe you might be thinking that, oh, should we hold it because they're vomiting and they have diarrhea, so maybe their blood sugar is dropping because they don't have adequate intake or they're not keeping the food in? Should we tell them to drink some cool fluids with high glucose because if they're having vomiting and diarrhea, we might want to replace glucose? Should we tell them to check their blood glucose levels every 2 to 4 hours? Or should we tell them to engage in a less strenuous form of exercise than usual until it resolves? And I know you all know the answer. It's number 3. So if a person has type 1 diabetes and you're ill, you need to test your blood glucose every 2 to 4 hours or even more often to determine what's going on. Keeping in mind that those symptoms, nausea, vomiting, and diarrhea, can be associated with DKA. So if you're holding your insulin and you already have an elevated blood sugar, critically elevated blood sugar, we actually could be compounding the problem. Most importantly, we're also going to make sure that patients know to come and seek help whenever they feel that there is a situation that they're not comfortable with. Don't hesitate to go to your primary care provider, walk-in clinic, or the emergency department. Let's try another knowledge check. Cardiac monitoring is initiated for a client in diabetic ketoacidosis, remember DKA. The nurse recognizes that this is a measure to identify what? Dysrhythmias resulting from hypokalemia, low potassium, fluid overload resulting from aggressive fluid replacement, the presence of hypovolemic shock related to osmotic diuresis, or cardiovascular collapse resulting from the effects of excess glucose on cardiac cells. And I know, again, you all know the answer. It is dysrhythmias resulting from hypokalemia. So just to keep in mind, cardiac monitoring does not tell us about, typically would not tell us about fluid overload. Cardiac monitoring tells us about the electrophysiology of the heart. Remember we talked about that PQRST, and it tells us about how that, electrical impulse moves through the heart. Presence of hypovolemic shock would not be diagnosed from a cardiac monitor. Cardiovascular collapse is not diagnosed through a cardiac monitor. And we've talked about DKA. One of the problems with DKA is we may see in the very early, when a patient preliminarily presents, we may see that high potassium, which is inaccurate, right? It's a result of not having insulin, which drives the potassium into the cells. So all that potassium has leached or come out of your cells. Once we move through a process of correcting the fluid level and then moving to insulin therapy, that potassium typically becomes quite low, so hypokalemia, and we need to move to replacement. Oh my gosh, and that is the end of this. So now I've covered everything in class, and this was what I had not covered, and I've recorded it here for you, and I did promise that I would record the rest of the class just for your convenience, and I will do that as well.